Hi, Puja. How are you?
Hey, can you hear me
Hey,
okay?
yeah, we can. How are you doing?
I'm good. How are you guys?
Yeah, not bad at all. Is the COVID situation better in your hospital now or still a problem?
Uh, yeah, I'm in the heart and heart of DC, so now we're struggling
Yeah.
with civil unrest.
Oh my God, that's another crazy thing happening at the moment. But has it affected day-to-day life as well? Are you finding it difficult to go to work?
Not for work. I actually don't live so far, so that's easy. But other
Oh,
people
okay.
are having a lot of difficult time because DC was had a curfew overnight.
Yes, I believe so. Yeah, we were just watching CNN actually, and it's giving us quite a bit of update.
Mhm.
Difficult times, huh? Difficult times.
Yeah, I felt as if one problem was not enough.
Yeah, I know. And the problem is with people coming together in such large numbers, you're going to have another surge,
Mm-hmm.
because COVID is not yet gone. It's still there, isn't it?
Right.
Are you
Yeah.
are you in your hospital or are you at home?
No, I'm at work.
You're at
We,
work?
I mean, yeah, you don't have to come to work unless things are going on. I had
Ah,
a short case in the morning, and then I have an admission coming in, so I wanted to stick around and take a look at the patient.
oh, all right, okay. But your residents are there as well,
Yeah,
24/7?
residents are there. They're short staffed. They're made into super teams, is what we're calling them, and
Oh,
they
I see.
work
Okay.
1 week on and 1 week off so that they can
And
conserve energy.
and they must be covering more than one specialty, isn't it?
Right, exactly. They cover more than one service for the time being. Since the
Yeah.
census is running low, we figured that probably makes more sense.
Yeah, that's what everybody's done. Even in the UK, we've done that. So we've
Oh,
got what is called as the super doctor. Same thing.
oh, okay. All right.
So
Same idea.
yeah, there are, yeah, same idea. So we previously had a concept called as doctor at night. So increasingly the hospitals are now going for one doctor at night, which covers more than one specialty. So cardiac, thoracic, and things like that. So the NHS is trying to cut down on its numbers. So the same concept now is brought into daytime as well.
Oh, yeah, sure thing.
And you guys have these auxiliary practitioners, isn't it? I think what are they?
Yeah,
Assistant,
APs, advanced
uh,
practitioner.
advanced practitioners and physicians assistants. So our in the UK they have come up with the auxiliary nurse practitioner (ANP).
Hmm.
So the nurses, the senior nurses on the thoracic services are being further trained, and now they can even run their own clinics actually. So they are called
Oh,
as nurse consultants. So some of them run most of the follow-up clinics and things like that. So yeah, it's a good idea to use manpower in a better way.
mhm.
Doctors are a scarce commodity.
Yeah, I know, right?
How much of esophageal work is going on at the moment, or is it all elective work is put on hold?
Elective work is starting to unfold now. During this whole COVID era, I did operate on two GERD patients and one
Uh-huh.
Achalasia,
Okay.
but we tried avoiding any patients if they didn't need a surgery.
GERD must be definitely elective, isn't it? I'm
Yeah,
assuming.
unless a patient is having recurrent aspiration. One patient called that he's been sleeping on 7 pillows, pretty much straight up night.
Oh,
Yeah,
blimey.
lay flat. So that qualified as a emergent surgery, not
Yes, of course.
particularly. And
Difficult.
another patient of mine was admitted at another hospital with aspiration pneumonia. So we took her as a transfer, let her get over the aspiration, and then operated on her.
Uh,
And then I
difficult.
operated on a
Esophageal.
Morgagni hernia, but she came in with bowel obstruction, so she needed to
Oh,
go.
I see. Okay.
And that's
Uh-huh.
different.
And do you do these open or do you these endoscopically? How do you do them?
I tried doing it robotically, but the Morgagni
Uh,
hernia patient was a pretty bad cardiac cripple, so I was a little worried that I
oh,
needed
I
to
see.
get her off the table very quickly. Actually, I
Sure.
was done in an hour, our time. We did it an open case. It was so nice
Uh-huh.
and I mean, I didn't have to grab the omentum and pull it down and tear everything apart. I mean, I
Yeah.
manually delivered it; it came right out, and then I was able to close
Excellent.
the case very quickly.
Excellent. And do you put meshes there or how do you close
If I
these
can,
defects?
this woman is handicapped, wheelchair bound, so I
Uh-huh.
didn't place the mesh. I only wanted to get her off the table quickly.
Oh, I see.
So, and the defect was such midline that had I placed a mesh, it would have caused me more difficult time to close the midline incision that I made. I did that open.
Oh,
So
I
I
see.
did.
Okay. So you could just primarily suture the defect, is
Right.
it?
I figured she's not going to bear weight and get up and try to walk
Yeah,
around. She's
of course.
morbidly obese, so might as well. There was no tension on the closure, so I was happy with it.
Oh, okay. Are you part of the cardiothoracic rotation, or are you a separate thoracic service?
We're separate. Thoracic actually, depending on the hospitals, but in our hospital, it tends to fall away from cardiac. Cardiac is its own service, and
Yeah.
thoracic falls under general surgery.
Oh, really? So the cardiac residents don't rotate through thoracic? Okay.
We don't have a fellowship at Georgetown. So we don't have cardiac fellows per se, but our general surgery residents who are interested in cardiothoracic, we make them rotate through cardiac service.
Oh, I see. So it's the reverse.
Yeah.
I was just discussing with some people in the US about, getting these sort of lectures set up in the American educational program. And this is the feedback we got, is that the cardiac surgeons, the cardiac residents don't really rotate through the thoracic things, and they're not really interested in thoracic.
Yeah.
And I believe that, the thoracic people have very good teaching programs already organized. At least that's what was the feedback.
Yeah, and I would agree with that.
Mm-hmm. Surprising, because really, I think all cardiac should rotate through thoracic at least for 6 months. Is it not part of the exit exam?
They rotate through. It's not that they don't rotate through, but they have very little interest in it.
Yeah, but is it not part of the exit exam?
It is.
Yeah, because most people fail in thoracic. In the FRCS, if you look at the failure rate, most people will fail probably in the thoracic section rather than in the cardiac section.
Interesting.
Yeah, so it's just cardiac, you see, they do day in, day out, but then they've never seen an esophagus in their life.
Right, exactly.
Yeah, so I mean, at Medanta, I mean, we have such a busy cardiac service, and they're all MCH cardiothoracic, passed out people. And I used to get reference for putting in a chest drain on the right side, or a reference as to what to do. There is an air leak. And it was just surprising. I would be shocked. I say, you're MCH cardiothoracic. Surely you know how to put in a chest drain. But for me, it was okay because it's all private practice. So that's good for me. It's income. But I strongly encourage my cardiac trainees
How are things in India as far as the ANPs or any advanced practitioners there?
No. There is really no academic teaching for any advanced ANP concept is not there. Some nurses are specialized and they sort of scrub in with you and for all cases, but they don't go on to become ANP. There is no system in the medical council to accommodate people like that. So it's just a different setup.
Right.
But I'll tell you, some of those guys who are trained are very, very efficient. Very efficient. I mean, but there is nothing where we can appoint them. I think I know of about 2 people in the whole of the country who are cardiac ANPs, but they are ANPs only in their local hospital, as in they've been trained by the local, whoever is the mentor, and he's got them to do a graduation or something like that. But there is no official training program like that. And those guys predominantly are people who take, veins and radial arteries and stuff like that. So they are more like a physician assistant in theater.
Oh, right. Makes sense.
But in the UK, we are coming up with that program. We are actually now starting to train, dedicated people to sort of take over as ANPs.
Right.
Yeah, so it's good. So did you train in the US all the time? Did you go overseas for any of your advanced fellowships or anything like that?
No, not overseas. No, I did my medical schooling, residency, everything in the US.
And you are a Washington graduate, isn't it?
No, I graduated. I did my general surgery at Emory, and then did
Atlanta.
At Brigham.
So Atlanta is Dan Miller, isn't it? Dan Miller runs the
Dan,
program
he
there.
used to be, he's not at Emory anymore. He moved,
Oh, really? Wow.
I'd say at least 4 or 5 years ago.
Oh, I didn't realize that.
He's within Georgia, but he moved to a private practice.
Oh, I see. Okay, yeah, because Dan I know Dan pretty well in meetings and all we meet, but I didn't realize he had moved. But actually, in the US, every time I meet people, they are in a new hospital.
No,
I
you're
don't
right.
know what it is. Everybody's moving all the time, you know.
Yeah, exactly. There's no consistency. It's like wherever the grass is greener, it's always
Yeah,
greener.
absolutely. It's a few 100,000 more, and you move your practice. It's amazing.
Yeah.
All right, we are reaching 5 o'clock. I'm just going to start the recording, Puja, and then we'll get going.
You'll share the screen, then I'll bring up my presentation.
Yeah. I'll do that. So you can start to share your screen, Puja, now.
Okay.
Start to share your screen, and I'll start recording. Have you got the permission to share screen at the moment or not?
No, it says host disabled participants.
Okay, let me just enable your thingy. Just 1 second. I'm going to just make you host for a minute, and then once you are the host, you can share your screen, and then I'll take over the hosting. So start sharing your screen. Okay, that's perfect. And now I will take over your hosting, so I can then look after the audience who logs in afterwards. Just 1 second. And before I do that, I need to start the recording. Okay, Puja, you're ready to go. Good evening, ladies and gentlemen. Welcome once again to another session of Thoracic Gurus. This is the 70th lecture in the series, and we are very fortunate to have with us Dr. Puja Khaitan, who has lectured previously with us on esophageal benign disease, and she works at MedStar Washington Hospital Center. Esophagus is her specialty, her domain, and today she's going to talk to us about gastroesophageal reflux disease and manometry. Puja, the floor is all yours. Take it away.
Hi, hello, everyone. So it's going to be a boring lecture, I'll warn you, but this is very essential. It's very essential for board questions and important for us to understand what manometry is. So if you attended my lecture a couple of weeks ago, I was talking about the esophagus, the benign esophagus, and I touched on reflux a little bit. But because I was sticking with more thoracic issues, I went into a Bell's-ear repair, which I won't go into today. So the main concept that I wanted to drive home was talk about some of the workup and then the manometry and what the components of the manometry are. So just we're all pretty aware of what typical symptoms are of GERD. I don't think we have to rehash that. Then, like I said last time, a typical workup for reflux is an upper GI. Usually a patient comes in with symptoms of reflux and they've gotten an upper GI, and you can clearly see that they have contrast that goes up and down the lower esophageal sphincter. You can find things on endoscopy, as including things like ulcers in the esophagus and reflux esophagitis, Barrett's, or even frank cancer, of course. If we don't have any evidence of GERD and don't have any documentation, and the patient especially wants to seek more treatment, they may undergo a Bravo study, which typically used to be a 24-hour pH study, and now it's a 48-hour or even a 96-hour Bravo study is out there. A Bravo entails placing a little probe in the esophagus about 4 to 5 centimeters above the GE junction. And then that probe looks at the number of episodes of reflux that you have where your pH falls below 4. And there are 6 different parameters that go into assessing the pH study. And in the end, you get what's called the Demeester score. And a high Demeester score greater than 17.4 is considered abnormal. And that's considered consistent with reflux, whereas a low score is usually saying that the patient's pH is controlled. So they could be on PPIs or antihistamines, and their acid reflux could be controlled. Typically, a pH Bravo study, if you're thinking of doing repairs, is done while the patient is off PPIs. to get a good understanding of whether or not they have reflux, because if you're on PPIs and you get a normal pH study, that could mean either you have no reflux or that your PPIs are working so well. Now, if you are on PPIs and you can't come off of it because you're miserable and you can't come off of it for 2 weeks before getting your pH study, and your Demeester score is high, which means your PPIs are not controlling your symptoms. So you do qualify for some sort of an anti-reflux surgery. So if you're considering patients to undergo a surgical repair, the two most important things that you should consider is doing a manometry on them to see how bad is their esophagus. Is it functional or dysfunctional? Because a long-standing reflux can make your esophagus dysfunctional. And like I said last time, plus or minus a gastric emptying study. So if a patient has acid reflux and has underlying diabetes and they don't empty their stomach through the pylorus, they may have elevated gastric emptying times. And that could be contributing to the reflux. So you don't want to do the wrong operation and then cause a tight esophageal sphincter, lower esophageal sphincter, and a tight pylorus, thus giving them a closed obstruction. So things that you should consider before doing a repair on a patient with GERD. When you're seeing them in your office, make sure you understand what their BMI is, because an elevated BMI of 35 or 40, you may want to consider that these patients may not just do well from an anti-reflux procedure, but they actually may need a bariatric procedure. So at that point, you should partner up with your bariatric surgeons and double check what's the right thing for that patient. You also have to consider whether or not what type of a fundoplication you will perform, 360-degree wrap or 270-degree wrap. If your esophagus motility is poor because of longstanding reflux or whatever the cause may be, you may not want to do a Nissen on them, because that patient is going to feel an obstruction at the esophageal end, and they will complain of a lot of dysphagia post-op. So those patients may benefit from a toupee. And there is a whole host of literature out there that suggests that patients may equally do well with toupee than a Nissen. If a patient has a pretty high esophageal sphincter, such as they've had a large type 3 esophageal hernia, paraesophageal hernia, and that you can tell that the GE junction is very high, you can pretty much imagine that if your endoscopy is showing you a GE junction that's anywhere 25, 30 centimeters from the incisors, you may not be able to mobilize them far enough to bring that GE junction below the gastric, below the diaphragm. And so at that point, you may have to do a wedge resection of the stomach to lengthen the esophagus, what's called the collis gastroplasty. So an appropriate counseling prior to the operation is very essential. And as well as the use of mesh or no mesh. That can be a whole host of another lecture, because there are people who are pro mesh and there are people who are strictly against mesh. I say if you can bring the diaphragm hiatus close together and close the defect, and then you can do the fundoplication without any tension, you don't need to put a mesh. But if you do feel that the stitches are falling apart, and no matter what you do with the hiatus, if you even put cledgets there and the diaphragmatic closure is not going to hold, then you should reinforce your repair with a mesh. Now, what type of mesh? Obviously, there's in the last couple of years, almost nobody uses permanent mesh. There's a lot of biologic meshes out there that will dissolve. You should try to make sure that they don't erode into the esophagus as you're placing the mesh. So it's important when you do your keyhole, you're around the esophageal hiatus appropriately. So now I wanted to mainly focus my talk on the high resolution manometry. And when you consider people of who are the people who undergo a high resolution manometry, they're typically patients who have reflux. So they have patients who have heartburn, regurgitation, they've had cough from long-standing reflux. They may have chest pain because of this heartburn. They even have hoarseness because of significant vocal cord bathing of the gastric juices. And then every few patients will complain of dysphagia, whether that's because of esophageal stricture, narrowing from the reflux, or a mass per se. Hopefully not a mass that you've diagnosed on endoscopy before bringing them to the OR for a fundoplication. So back in the day, we used to do conventional manometry, but over the last 5 to 6 years now, almost every lab has now adopted what's called a high resolution manometry. And I just wanted to highlight the difference. So this conventional manometry is the image that you can see on the left, and it can be performed with the use of a low compliance system. we don't do this anymore because if you can take a look at this image, a typical probe that was placed in order to get the manometry reading used to have pressure sensors that were about 3 to 5 centimeters apart. And unfortunately, because this catheter was not, you could not leave this catheter in for a long period of time. In fact, when you did these manometry readings, there was a stationary pull-through method that was used to determine the position of the lower esophageal sphincter. And then to identify the inversion points and the pressure zones, you actually had to pull the manometry probe back every few seconds as the patient swallowed to get the whole reading. So obviously this was very painstaking both for the patient as well as the person performing the manometry. And therefore this high resolution manometry that's seen here on the right has come out. It generates a detailed pressure topography map of the esophagus and identifies compartmental pressurization in the distal esophagus. And it generates this nice colorful map of the esophageal body. So just to give you some technical details, high resolution manometry probe is a narrow catheter. It's composed of multiple closely spaced pressure sensors. They're usually about 1 centimeter apart. And it provides much more information than a conventional manometry. Data is not lost in these 3 to 5 centimeter size gaps between these sensors of a conventional manometry. There are several advantages of a high resolution manometry. The main innovation of this method is the conversion of that pressure data that you get from a manometry reading into this topographical plot. And the data can be modified using interpolation to generate these pressure plots that are color-coded. They are spatiotemporal representations of pressure recordings in the esophagus. They're called Klaus plots. Also, high-resolution esophageal pressure topography is not synonymous with high-resolution manometry. Although high-resolution manometry and HREPT are not synonymous terms, the manometry is necessary to create this topographical plot. In contrast to the station pull-through method of the conventional manometry, these high-resolution manometry assembly needs no further repositioning once it has been placed across the GE junction. It makes the procedure much more comfortable for the patients for obvious reasons. And then you get simultaneous assessment of the upper esophageal sphincter as well as the lower esophageal sphincter and the esophageal body peristalsis with a single series of swallows. That makes the data acquisition period much shorter, about 8 minutes than a conventional manometry, which is almost triple times that. The pressure sensors are spaced in such close proximities to each other that by interpolating between the sensors, intraluminal pressure is represented as a pressure continuum from the pharynx to the stomach. Now, how do you read these plots? If you look at a plot, the time is placed on the x-axis and the sensor position is along the y-axis. So it kind of documents the pharynx, esophagus, esophagogastric junction, and the stomach along the y-axis. The upper esophageal sphincter is the top of the graph, and the bottom of the graph is usually the lower esophageal sphincter. The center of the transition zone is labeled as the proximal proximal pressure trough, like the P here, which corresponds to the other graph. And the distal relaxation point is the distal pressure trough, as a D here. And then the esophageal body is labeled from P to D. And the colors are assigned to these pressures with cool colors, blue and green for lower pressures, and warm colors, red and yellow for higher pressures. Now, analysis of a plot study is performed by using a stepwise approach, focus on an algorithm-based scheme that first assesses the GE relaxation pressures and subsequently uses individual swallow patterns defined by these plot metrics. The first step of the analysis process focuses on describing the pressure morphology of the GE junction to determine whether hiatus hernia is present. So that's the first thing you always look at when you look at a plot. And where the pressure inversion point is located at this, as this can have dramatic effects on the measures of the GE function. I'll tell you what I mean by all this in a minute. The baseline end expiratory pressure and an inspiratory augmentation are recorded to assess the integrity of the crural diaphragm as an extrinsic sphincter. And then assessing the GE junction relaxation and bolus pressure dynamics through the GE junctions, you can use those numbers to define other parameters, such as integration relaxation pressure and the DCI, which I'll get into in a few minutes. So this is how you look at the process of doing the manometry recording. The first thing that you do is when patient swallows a probe, you determine the LES pressure by looking at the inversion point. And the pressure of this inversion point is the level at which the pressures of the lower esophageal sphincter, they transition from a positive deflection of the intra-abdominal to a negative deflection where it's intrathoracic with inspiration. And on this picture, you can see this is a perfect patient with a lower esophageal sphincter spanning from 29 to 32 centimeters. That's usually measured from the upper esophageal sphincter, not from the incisors here. You can see how the PIP aligns with the LES, which would be perfect because if your diaphragm is where your lower esophageal sphincter is, then that patient doesn't have a hernia. An integration relaxation point is an interesting concept. It's so if a patient swallows a bolus, this is the upper esophageal sphincter and this is the lower esophageal sphincter. You guys can see my arrows, is that correct?
Yes, we can.
Okay, great. So as a patient swallows a bolus, our normal human reaction is that the lower esophageal sphincter immediately starts to relax. And as the bolus swallows down, it tends to relax so much and open so that the bolus can pass and creates a higher pressurization zone through the lower esophageal sphincter as the bolus passes. That allows the bolus to pass down in a normal peristaltic fashion. So
yes.
Okay. Great. Sorry, did somebody have a question?
No, please carry on. I think somebody just switched on the.
Got you. Okay. So an integration relaxation pressure is the 4-second is the lowest pressure in your at the lower esophageal sphincter for 4 seconds during your deglutition period. And you want that pressure to be the lowest in order for you to say, okay, you have normal relaxation of your lower esophageal sphincter. So if you have a high IRP, that usually suggests that you will not do well. And the patient with achalasia, for instance, will always have a high IRP because they're unable to relax their lower esophageal sphincter. On the other hand, a patient with reflux may have a normal IRP, or they may have even a slightly lower than normal IRP. So usually they'll run into 8 to 10 range. Anything less than 15 considered normal. A DCI is actually the pressure of the esophageal body, and somebody who has a high DCI, the range is pretty high, 500 to 4,300. A patient who has a very high DCI, that means that they have clearing issues. They have issues with clearing of their bolus of their esophagus food. If you have a low DCI, that means your esophagus really doesn't have much contractility and you're unable to generate that pressure. Now, these are terms that are used typically by a gastroenterologist who's using them, who's looking at a esophageal manometry and determining all these other numbers. We don't typically come across CFV and CDP in surgery, and we don't talk about it. But just to give you an idea, when a manometry is done, and after this, the 10 swallows are all processed into an image, a good GI lab will have a gastroenterologist who will look at these manometries and then make sure that the data is appropriately aligned. Because when you do this sort of a study, the computer has an artificial intelligence program implanted in it, and it'll give you all these, upper esophageal sphincter and lower esophageal sphincter. But a GI doc can at least take a look at these graphs and almost always will tell you that the automated mapping does not accurately maps all the parameters correctly. So they often have to shift the curve of where the upper esophageal sphincter is, where's the deflection, deceleration point, where is really the lower esophageal sphincter, and whether or not there's a hiatal hernia or not. So the things that they also look at is something called the contractile front velocity, which is the slope of the tangent between the P and the CDP point. It tells you how fast is your esophagus accelerating. And like I said, the CDP is a deflection point, and that's where your propagation of your striatal and smooth muscles kind of become more defined because you're approaching the lower esophageal sphincter. A distal latency is an important concept. However, we do use this when you're considering anti-reflux procedures. This is the interval between the upper esophageal relaxation and the CDP. So if a patient does not clear this bolus out quickly, usually being less than 6 seconds, if you swallow your food, your food swallows from your upper esophageal sphincter to the CDP within 6 seconds. If it gets stuck and there are higher pressurization points, and the food bolus passes more slowly, so your distal latency is higher, that patient is not going to do well with a complete wrap. So that's why it's important to look at your distal latency numbers when you actually get your manometry reads. So what is normal? This is what a normal the esophageal pressure plot will look like. So the upper esophageal sphincter is here. As soon as you swallow a bolus of food, this is swallow number 6, this is swallow number 7. You have a contraction of the upper esophageal sphincter, your lower esophageal sphincter tends to relax, and the bolus passes down. If a patient has a hiatal hernia, you will see 2 separate bands, one here and one another band higher up. This is not a band, this is a background reading. So you would see another pressure band that you can tell that the patient's diaphragm is someplace else, and then you have 2 different deflection points. This is a patient with a scleroderma. I wanted to just highlight that because if you do a patient, you operate on a patient who may have underlying scleroderma, they may come in complaining of reflux. Their upper GI may show that they have reflux, but they probably don't have any motility in their esophagus. And their esophagus latency period are long. And if you try to operate on them and do an anti-reflux procedure, they will not do well with a Nissen. So they may need a toupee, for instance, or nothing at all, depending on what their symptoms are and what kind of outlet obstruction symptoms they have. And this is a patient with achalasia. Probably not the best image. There are much better images out there, but this patient has no motility. You can see that their lower esophageal sphincter is pretty tight and it does not relax with any boluses. So that's a lack of aperistalsis and pathognomonic sign of inability to relax their lower esophageal sphincter. The way these numbers all came up, back in 2009, when all this high resolution manometry was being done, they performed manometries on 50 healthy patients to determine whether or not they had, sorry. Can you guys see me again?
Yeah, we lost your screen. So I'm going to again make you, I'll make you the host and you just start sharing and then I'll take it back. So start sharing your screen again. We lost your screen.
Yeah.
You got it back. Thank you.
Okay.
Thank you.
So when you, so based on these, the numbers were determined by looking at some 50 healthy volunteers. So the numbers are not perfect, but they do work very well for the most part. And if you look at somebody, some of these manometry reads, they will give you the numbers for the lower esophageal sphincters, the length, what the normal pressure should be. And so based on all these, they've come up with these numbers, the ones that I was telling you about, DCI, IRP, and the distal latency. So I also wanted to show that if a patient has reflux or achalasia, you must make sure that they have good relaxation of their lower esophageal sphincter, because if they have incomplete impaired LES relaxation, you may not want to do a Nissen fundoplication on them. So it's important, while we all think of just performing a fundoplication is simple, if you want good outcomes on your patient, it's important to look at the manometry yourself. So I almost always get the manometry out and take a look at all these colored images so that I have a better understanding of their esophageal motility. So, and manometry is also important in achalasia patients. As we all are aware, there's a Chicago classification that tells you what kind of an achalasia the patient has, whether it's type 1, type 2, and type 3. So you look at their integrated relaxation pressure, and like I said, they have to have an elevated number. That's why their GE junction is not relaxing, and that by definition is achalasia. And if you don't have that, then you may be dealing with another medical condition. You're not dealing with achalasia. If your IRP is high and you don't have achalasia because you don't have failed peristalsis, then most likely you have some sort of an outlet obstruction. Whether this is just the starting phase of achalasia where you still have some contraction of your esophagus, that's possible, or it could be a mechanical obstruction, especially if a patient has had a prior hiatal hernia repair. You may want to consider that they have what we call pseudoachalasia. So there's something wrong. When your IRP is high, there's something wrong with GE junction outflow. And that's why they classified on top here. Now, if your IRP is normal, then you fall to this 3, 4, and 5, and then you look at your distal latency and your peristalsis. So if you have a short distal latency or a high DCI, or you've got failed peristalsis, then there's something else that's wrong with your motility of the esophagus. So what we call either you have diffuse esophageal spasm, jackhammer esophagus, or you just don't have any contractility, such as scleroderma. If your IRP is normal and you've got some ineffective swallows, or if your IRP is normal and you've got some effect, greater than 50% effective swallows, you may have something that's minor. And this is where you may end up falling into GERD issues, where you have ineffective motility. However, you don't have a motility disorder of your esophagus. So these patients are typically okay to undergo a anti-reflux operation. This is a typical picture. So this is a type 1 achalasia patient with no peristalsis, a high IRP or a high LES pressure zone the entire time. This patient has type 2 with some panesophageal pressurization. And as we all know, type 2 achalasias are the patients who do the best after Heller myotomy, for instance. And type 3 ones are the ones that you have to educate them that they've got some esophageal spasms, their esophagus randomly fires, and that even though you may fix their hernia, their outlet obstruction, their achalasia, you will not do anything for the esophageal spasms. So they may complain of these excruciating chest pains even after surgery, but you just have to educate them that unfortunately is not something that can be fixed with your POEM or your Heller myotomies. These are some other images. So these are obviously very bad examples of somebody with achalasia. You can see this patient has type 1, although you could even categorize this as type 2 because there is some pressurization of the esophagus. This is higher pressure in the esophagus. And then this is a patient who has type 3 who has got a very diffuse esophageal spasm that hurts while they're swallowing. These are patients with some GE outflow obstruction. You can see that their lower esophageal sphincter doesn't completely relax, especially when the bolus comes down. This is a patient with more spasm. They have more spasm that goes in a linear fashion. And then jackhammer patients tend to have a higher pressurization zone of greater than 300 millimeters of mercury. This is a classic achalasia patient again. And then this is the minor disorders of peristalsis. This can be related to anti-reflux procedure. This can be related to GERD itself. This is a patient who has an ineffective motility. You can see that the lower esophageal sphincter tends to relax. You can get an IRP on this patient, which is low, but they don't have good peristalsis because the constant bathing of the gastric juices within the esophageal body has made them quite miserable. This patient has fragmented peristalsis, so it kind of breaks up as you swallow, so you don't have good effective peristalsis. And then obviously this is a patient with normal peristalsis, so this patient will benefit from a anti-reflux procedure such as a Nissen, but these patients would warrant a toupee. And I actually went quite fast through all that. That's pretty much all I had. It was a pretty dry talk on that. think I want to add more for anti-reflux. I think we can make that a different talk, but I'll be happy to answer any questions because I know this topic is actually pretty laborsome and very hard to understand.
Okay, thank you, Puja. Thanks very much for taking us through the manometry of GERD. Uh, since we've got all candidates who are exam going, can you tell us how these questions are asked in the board? How is the sort of, do they give you a high resolution tracing and you're supposed to
Right.
read it, or do they give you a clinical scenario and you're supposed to read it?
They tend to do both, just to take out some of the possibility of guessing. They'll give you the numbers, but they'll give you a map, and then for instance, for an achalasia patient, they'll just tell you that this is a manometry you get on a patient who presents with symptoms of dysphagia and regurgitation for the last 2 years. What are the chances? What will you do with that patient as far as for surgery? And what they're trying to do is they're asking you to guess that the patient has achalasia, and you're going to do a Heller on them and not an anti-reflux operation. So that's typically where they'll give you. They won't ask you to interpret it per se. I've had other residents, I've personally never had it, but I've had other residents who told me that they were given a picture of a manometry during their oral board exam and asked to say, can you tell us what you see?
Yeah, I think in the FRCS exam as well, they give you a visual picture, and they ask you, it's just for the FRCS exam going students. They actually give you this manometry traces. So which are the important ones that they must sort of recognize at a glance?
So I realized as I was giving a talk, I should have included a nicer picture of a hiatal hernia. So the classic ones that we get is a patient who has a hiatal hernia or paraesophageal hernia, and you'll see two bands. You'll see this one green band, and then you'll see a second very distinct green band. And this the esophageal body will come and terminate on the first band. And really, you won't see a whole lot of function between the first and the second band. That usually suggests that the patient has a large paraesophageal hernia where the diaphragm is higher up, and or sorry, the lower esophageal junction is higher up and the diaphragm is lying below, thus suggesting that the lower esophageal sphincter is it's more elevated and has an intrathoracic position. So that's one classic one. And then the other one that they like giving is a patient with achalasia where you have no contraction. But typically the one that you will get is a picture like this, which is a no-brainer. They're not trying to trick you. They just want to make sure that you understand the concepts. They understand you're not a GI doc, and you don't sit in a GI lab to interpret all these all day.
Now, if you have reflux esophagitis, there are various classifications of reflux esophagitis, isn't it? There's the Los Angeles classification, then there's the Savary-Miller's grading system. Can you use pH studies to actually differentiate between the various grades?
No, those are defined by what you see on endoscopies. So those are defined by the amount of what's called CNM numbers. So they are defined by looking at the circumferential involvement of the esophagus by reflux. And whether or not, how deep are the ulcers, how many ulcers do you see in the esophagus? So those are endoscopic findings. They are not.
So they're not on the basis of manometry at all.
That's
right. And once you've seen this manometry findings, how do you decide which patient's going to have medical management, which patient's going to have surgical management?
So you're probably getting to the manometry if you're thinking surgery. You don't do manometries on patients who you're medically managing. If your medical management has failed, then you will say, okay, let's do a manometry to see how your esophagus is doing before I consider an anti-reflux operation. But so your more important point is a pH probe study. Is when will you do a pH probe study, whether or not you're being controlled on your PPIs or not?
Okay. So basically, what is the sequence of investigation? That's the question I was going to ask you. So
Okay.
you've got a patient who comes into your clinic and you've got the guy saying, I'm getting reflux, I'm getting GER, these are sort of symptoms. So what is your sequence of investigations in the clinic? How do you work up this guy?
So a typical patient is probably just complaining of anti-reflux symptoms, and they
Yeah.
may be popping some things over the counter to see if their symptoms get better. If they tell you that I take, in US, we call them at least Tums, which is the most common word for popping in antacids over the counter. Then, and they say that when I take Tums, I get better for a day or two, and then my symptoms start to come back. So that by definition will say, okay, you've got reflux, so let's do some studies on you. And a patient with an upper GI, you can determine that they have some sort of a lower esophageal sphincter that's lax, that allows them to have reflux. And then if the patient states that they are having symptoms that are PPI that are consistent with reflux and sound like reflux and they look like reflux in an upper GI, you can get typically started on these proton pump inhibitors. And if their symptoms go away, you may not have to do anything else besides that. However, there's a growing number of patients now who say that I don't want to be on PPIs lifelong. I'm concerned that I may have cardiac issues in the long run, or there's a small study that says that PPIs is related to osteoporosis as well. So if there are females, they'll come in and say that we don't want to take PPIs lifelong because we are at risk of osteoporosis. Then you say, okay, fine, let's do other investigational workup. And that's when we do a pH Bravo study to see if their symptoms are not controlled on PPI, then let's operate on you. If they want to come off of PPI, you take them off for 2 weeks and then do their Bravo study. But if they do their Bravo study and they have normal numbers, normal Demister score off PPIs, then you have to wonder if there's some other underlying condition that they don't have reflux. And you probably should do more further workup to see what's causing their problems.
So then you go into a manometry. So manometry is never sort of your first line investigation.
Yeah,
it's always the last one.
Yeah, it's almost when you're thinking just before surgery is when you do the manometry.
So manometry helps you decide whether a patient is a correct candidate for surgery, and does it also help you decide what type of surgery to do?
So manometry helps you decide what type of a wrap will you do. Will you do a 360-degree wrap or a partial wrap, 270-degree wrap? Now, if you there are surgeons out there who don't believe in manometry. Very few and far between, but they will say that manometry doesn't add anything to their decision-making process, so they'll forego it, but then they'll commit all their patients to a tupé fundoplication, only because they don't want to put a 360-degree wrap and have issues. If I have a younger patient, somebody who's 40 and 50s, I really go the extra mile to convince them that they should get a manometry, because there are patients who will say, oh, I don't want anything sticking in my nose. I don't want a manometry done. Or I went there and I was having such a difficult time. I don't think I can do it again, doc, so I don't want it. So on those patients, I try to convince them that a Nissen would go a longer way for you. So let's try to do a manometry for you.
Would you do an endoscopy as the first line in all your patients?
It's not the first line. Some patients who come to our office have been diagnosed with reflux based off on an endoscopy.
Yeah, no, because these guys will have a case in the exam, a long case, who presents. They'll take the history and they'll do the clinical findings, and then they have to present what is their sequence of investigation. That's why I'm trying to sort of,
I would always say upper GI is the first thing, because you'll find a tons of questions from your upper GI. Because if you've got a large paraesophageal hernia, you don't have to commit them to a Bravo study, right? That hernia needs to be fixed anyways. Why would you do a Bravo study on them? And same thing with an endoscopy. I mean, if you've got a large hiatal hernia, you know by definition they have it. Now, when you're operating, you should always do an endoscopy. I would say if the patient has not had an endoscopy before and you're operating on them, make sure you complement, at least for boards, make sure you say you're going to do an endoscopy. Mainly because what if you find something you didn't expect before and you don't want to miss it? So if you do a patient with upper GI that shows a large paraesophageal hernia, you operate on them, and 2 months later they come in with obstruction and they get scoped, because they're going to trick you. and then tell you that now you scope them and you find cancer. Well, why didn't you scope them 2 months ago when you actually did the anti-reflux operation? Because now the patient has stage 4 cancer when you could have diagnosed them at stage 1 or 2.
Okay. And what is the role of barium swallow studies in all of this?
So same concept, the upper GI, it's a good question you asked. Thanks for bringing this up. So when people talk about an esophagram, an upper GI, and a small bowel follow through, I don't know if those are the same terms that are used in different countries, but in the US, we say an esophagram is just looking at your esophagus. And you look at the contrast that goes just at the lower esophageal sphincter, and you terminate the study pretty quickly, right as soon as it enters the stomach. An upper GI looks at the contrast that goes through the esophagus, through the lower esophageal sphincter, into the stomach, and empties through the pylorus. So if you wanted to do a workup for GERD, I always say do an upper GI, not a barium esophagram, because in an esophagram, they may terminate the study as soon as they see the contrast has made it through the esophageal sphincter and then stop. I like to see if the contrast has made it in the pylorus, because sometimes on an upper GI, you'll be told by the fluoroscopic radiologist that we see contrast hanging up in the stomach and has not completely evacuated. Then you know that there's something else wrong with that patient. Then you'll get a gastric emptying study, for example. But if you just do the esophagram, you'll miss that information. You don't need to do an upper GI with small bowel follow through. Typically, that's a 4-hour study. The patient is usually held in the radiology lab, and they get routine X-rays of their abdomen every 30 minutes or so to see how fast is the contrast moving through the bowel.
So you would do a barium swallow in all your patients with GERD, or would you not? What makes you decide?
For the most part, we pretty much do it for almost all patients. It gives you the lay of the land, exactly what you're dealing with when you get into the chest or the belly.
Okay. Any role of CT scans in this?
Usually not. We do get patients who come into an outside emergency rooms, for instance, saying that they have abdominal pain, and they get diagnosed with paraesophageal hernias because they got scanned for abdominal pain. And then you see that there's a gastric volvulus. If the patient came in with excruciating abdominal pain and not in your office, but you're seeing them in the emergency room, most often then you'll have a CT scan on them. And first things first, you don't go and operate on them. You're not going to start doing all this workup, right? The first thing you'll do on a patient who came into the ER with symptoms of nausea, vomiting, or abdominal pain, you're going to place a NG tube, a nasogastric tube, to decompress their stomach so that they can get decompressed and see if their stomach, which could be volvulus, whether volvulized, you want to make sure that they detorse their stomach. You will check labs on them that they don't have an elevated white count or a high lactic acid to suggest that they may be ongoing ischemia. You may have to resuscitate on them. And then you have to have a low threshold of operating on them during that admission. But overall, you don't get CT scans on a routine basis.
Okay. Now just diverting a little bit purely for the exam going students, the pharmacological management or the medical management includes antacids, alginates, H2 receptor antagonists, proton pump inhibitors, and prokinetics. How do you decide which one to give to the patient?
So for the most part, we will start patients on either the antihistamines or the proton pump inhibitors as the first modality. If they've got gastric emptying issues and you are concerned that they have long-standing diabetic, then you'll add the prokinetics to it. But prokinetics, as we all know, is not a good long-term plan. For instance, the metoclopramide can have long QTC intervals, derangements, and the patient can have arrhythmias. At least in the US, the erythromycin, which you would think would be a very cheap antibiotic as a pro-motility agent, is pretty expensive, so most insurances don't cover it. So we run into that trouble. So in those patients, if they've got issues with emptying of their pylorus, you may have to complement those with pyloric drainage procedures or Botox injections. But for the most part, what we do is you start the patient off on PPI once a day. If that doesn't control their symptoms, you can go to BID twice a day. And then you can add antihistamines. Antihistamines is always once a day dosing. They're not twice a day. So we will say, okay, if you're maxed out on medical therapy, which includes twice a day of your PPI and once a day of your antihistamine, then you failed on medical management. And at that point, you should undergo surgical evaluation. Unless the patient says outright, I don't want to be on this lifelong. I want to go see a surgeon earlier.
Okay. What is the role of H. pylori and triple therapy?
So H. pylori is definitely a factor that does increase your incidence of GERD. That's not the right word, an association of GERD. So when you typically get your endoscopy, and if you see significant amount of reflux esophagitis, especially gastritis, biopsies are done. And if you do have H. pylori, you should treat them with their triple package for at least 14 days before pursuing any further workup. Because it could be that the H. pylori has caused their anti-reflux symptoms and that they may not have a true reflux picture underneath.
Okay. And what is the incidence of Barrett's esophagus in these patients with GERD?
I won't know an incidence offhand as far as how many patients with reflux have Barrett's, but Barrett's, as you may know, when you look at an endoscopy picture, they look like salmon esophagus, for lack of a better word. Let me see if I can Google something. You guys can still see my pictures?
Yeah, we can see you now. We've lost sharing the.
Oh, I see. Okay, 1 second. Let me pull something up and.
I've made you host, and you can share your screen in a minute.
Okay.
So while we are on Barrett's, can you tell us a little bit more about Barrett's? What's the principle of management in a Barrett's patient?
Absolutely. So this is what a typical picture of a Barrett's looks like. This on the right. So this is normal, healthy appearing mucosa of the esophagus. Looks a little whitish and more bland. And this is the salmon colored mucosa is what's Barrett's. And they're called salmon tongues that are coming up. You can see that this is not a distinct lower esophageal sphincter. A lower esophageal sphincter is more well defined than this. Maybe I can pull up a picture of that. And you'll see a very nice contour to it when you're looking at it endoscopically. And the other thing I wanted to highlight was, so this is a normal appearing lower esophageal sphincter. Did I lose it? Here. So see how nice that transition is from your upper normal esophageal mucosa to your gastric mucosa and brugal folds coming up from the stomach. You also look at these Barrett's esophagus under NBI mode. So when you're looking in every endoscope, there's something called an NBI mode, narrowband imaging. It looks at two different wavelengths of, I forget, it's 460 and 570 nanometers wavelength. So this is a normal looking, nice little esophageal mucosal plexus that you can see. And a patient who's got Barrett's, so if this is the Barrett's, you can see they clearly look abnormal. So this, see how that was a nice normal transition? This is a tongue of Barrett's coming up. And if you were to biopsy that, you would get some sort of a metaplasia or dysplasia. This itself can be a different talk actually. So you actually, when you look at the patients and you scope them and you biopsy them, you get low-grade dysplasia and high-grade dysplasia. Back in the day, we used to operate on patients with low-grade and high-grade dysplasias, but nowadays we say that these patients can be managed with PPIs. If you do have high-grade dysplasia, you have to complement your treatment modalities with some sort of an endoscopic ablation. And typically we use we used to use cryoablation. Typically we use RFAs, radiofrequency ablations, where you ablate that mucosa. Now, one thing you have to make sure is you don't miss a nodule while you're doing all these biopsies. If you miss a nodule, it can have hidden esophageal cancer. And then these patients will need surveillance very closely to make sure that no dysplasia or metaplasia is coming back.
Just explain the difference to us between these three terminologies. High resolution endoscopy, autofluorescence imaging, and narrowband imaging. You just showed us narrowband imaging. What are the other two terminologies? What is HRE and AFI?
So high resolution endoscopy is what we typically do. That is what we, the scopes that are designed have become high resolution. So just like any pictures and videos that we see as high resolution, that's what that is. Autofluorescent imaging is used for similar thing than this narrowband imaging. So NBI falls under that autofluorescent imaging. And you can use different imaging modalities. People used to spray acetic acid inside the esophagus to look at these barrettes and look for different features. So it's the same concept. It uses fluorescence to detect dysplasia. But now, for the most part, under autofluorescence, narrowband imaging has become the predominant modality that we use. Unfortunately, that NBI mode has now become integrated into high resolution endoscopy. So all these terminologies have blended in.
So it's all one eventually.
Right.
So what's the role of EMR, endoscopic mucosal resection? And tell us a little bit about POEM. I'm sorry, I'm pushing you a little more, but just
we have time.
For the sake of the students, I want to get some more information.
Yeah, of course. So EMR, endoscopic mucosal resection, and ESD, endoscopic submucosal dissection, are terminologies that we use to excise suspicious nodules. If you are doing an endoscopy and you find a nodule and you think it looks superficial, one thing you can do, and I would say this on boards, although not all gastroenterologists practice this, is that I would inject a saline bolus underneath the nodule to double check that it lifts away from the underlying submucosa. If it does not lift away nicely and that gives you a plane, then it's deeper than the mucosa and it's gone into the submucosa, what we call a T1B lesion of the esophagus. And that patient will not benefit from an endoscopic resection. You guys can still see my screen?
Yes, we can.
Okay. So when you do an endoscopic mucosal resection, it is a different type of a scope that you use in the patient. And what you do is there's a little suction cap that goes in. So you go in and you inject underneath the nodule. If it lifts away, you can use this technique to then try to remove that polyp. But when you remove that polyp, that snare must come down on the neck of that lesion so that you can actually remove that lesion in its all entirety. And the important part is, while your radial margin should be negative, the most important concept is your deep margin should be negative, that you don't leave any cancer behind. Because if your radial margin is negative, you can do another dissection, or you can do what's called an ESD, which is endoscopic submucosal dissection. So you can take your endoscope and you actually lift this up, and then you take a razor or knife through this endoscopic tool and make a plane all throughout to take that lesion as one, or you can do multiple EMRs in one patient. But the important part is that you should make sure your deeper margin is negative.
So your EMR is therapeutic rather than diagnostic. Is that correct?
You can use it for both purposes. Some people say that I don't have biopsy proven cancer on this patient, and I want to make sure that this nodule is not cancer. So now I'm not going to take a biopsy. I'm just going to do a submucosal resection. And if it comes back as an esophageal adenoma, then you say, fine, I did a therapeutic surgery for this patient. And if I'm had cancer, then you can make it say that this was a diagnostic and therapeutic for the patient.
Okay. And tell us about POEM.
POEM is a procedure which stands for per oral endoscopic myotomy. That is done for patients with achalasia. So patients who have dysmotility of the esophagus, a POEM procedure is performed by a different type of a scope. The way it's done is that it's conducted throughout the entire mucosa, esophageal mucosa length. You make an incision in the mucosa. It's an intra-esophageal dissection. So a Heller myotomy, as we all know, is a myotomy of the lower esophageal sphincter, where the the muscle layers, especially the circular muscle, is filleted open so that your esophagus mucosa can bulge out. Now think of cutting that circular muscle from the inside without going to the abdomen and going into the longitudinal muscle fibers and then cutting the musculus muscle. Think of it the other way around. So if you come in through the esophagus, go about 14 centimeters proximal from the lower esophageal sphincter, make an incision in the mucosa, and then create a submucosal tunnel with your endoscope, getting all the way down to your stomach as well as your lower esophageal sphincter, and you cut the muscle fibers on the inside. Then you withdraw the endoscope as you're coming back, and then you put a clip on your esophageal mucosas. That esophageal mucosa clip will fall off within a period of days. The important part of this is, just like a Heller myotomy, when you make the myotomy, you have to cut the esophageal mucosa, the esophageal muscle of the lower esophageal sphincter, but also make sure that you carry out that myotomy beyond your lower esophageal sphincter onto the stomach, so you don't end up getting an incomplete Heller on a patient.
So you spoke to us about POEM. You told us about endoscopic mucosal resection. You were saying something about endoscopic submucosal resection. So do you use the same scope as an EMR, or do you use a POEM scope? Is it something
it's
different?
not a POEM scope. I don't know the good answer, only because I don't perform it. If the submucosal dissection scope is different from the EMR scope. So EMR, ESD are complementary studies. They are performed to do a submucosal dissection. I would think it's the same. What you do is that you do you inject the nodule, the lesion, and you lift this plane, and then they're using this little laser knife through your endoscope. You cut the submucosa so that that lesion can come as one en bloc specimen.
Okay.
And an EMR is appropriate for a lesion less than 2 centimeters, but anything bigger than that is not appropriate for EMR, and you should consider an ESD.
Okay. Now there's a question from the floor. Dr. Yaldo is asking us, what are your comments about the statement in some literature saying H. pylori eradication has increased the incidence of esophageal cancer?
Well, we think H. pylori causes an increase in acid reflux. Whether, I don't know the exact mechanism, but from what I recall in the past is that there is a mechanism that causes H. pylori to have increased acid production. So untreated H. pylori over a long period of time will put you at risk for increased acid reflux because of increased acid production. It will also predispose you appropriately to duodenal ulcers for that reason, and then therefore be associated with esophageal cancer, especially if you have a lower esophageal sphincter that's lax.
But the question is eradication of H. pylori. Does that lead to esophageal cancer?
I don't know the answer to that.
Okay. So
is there
sorry, Dr. Aldo, we don't have an answer to that. We'll have to look at these papers which you're talking about. Anybody else has any other questions? Please feel free to switch on your microphone.
I have a question, sir.
Hi, that's Dr. Vikas for you.
Ma'am, you said there are some surgeons who don't believe in doing manometry before the procedure. That is for GID per se, not patients who have hiatal hernia. In hiatal hernia, we always do a manometry, right, ma'am?
So no, there are people who will say type 3 paraesophageal hernias don't warrant a fundoplication, don't warrant a manometry, because they will do a two-pay fundoplication on all of them.
I'm sorry, go ahead, ma'am.
Why they say that is because these surgeons believe that because they've got a paraesophageal hernia, usually a type 3, where the stomach is stuck in their intrathoracic mediastinum, they say that their esophagus has been there so long, and this didn't happen overnight. This has happened for so many years. I can guarantee you that whatever you do, their manometry will not be normal. So they don't trust their manometry, and they say, well, I'll do a two-pay on all these patients.
So they have pre-decided that whatever anti-reflex I'm going to add is two-pay only. Otherwise, the reason to do a manometry is we want to decide whether we want to do a Nissen or a two-pay, right?
Correct.
Is there any other reason we do a manometry in hiatal hernia?
If you think that the patient, for instance, I actually had a patient with rheumatoid arthritis, and she told me that her daughter had Crest syndrome. I actually suspected there's something else that's wrong with her. And she did not have a hiatal hernia. She only had acid reflux. So I insisted that she gets it. She didn't like it the first time, so I was making her do it the second time because she went to go see another surgeon, and I was her second opinion. So I told her that, no, I think we need a manometry. And I'm glad we did, because she actually turned out to have scleroderma.
Okay. So if we have a patient with GERD and I want to make sure whether the patient has hiatal hernia or not, what is my investigation if that question is put to me?
Repeat that question.
If I have a patient who is coming with GERD and I want to make sure the patient does not have a hiatal hernia, so only upper GI scopy will tell me that, right? Or I do have to do something else?
No, if you don't suspect the patient has a hiatal hernia, I mean, you get an upper GI.
Yeah.
The upper GI is a very simple study. It's non-invasive. The patient goes in and brings the contrast, gets some x-rays, and that's it. So at least you'll find out that whether or not the patient has a hiatal hernia or not. If you get an endoscopy, you don't have to have an endoscopy on those patients, but do the endoscopy at the time of the operation.
Okay, right.
So before the operation, you don't have to put them through an endoscopy. That patient will likely need a pH Bravo study because A, they don't have a hernia, and you have not documented in any shape or form that the patient has a reflux.
Yes.
Cause the symptoms. You don't want to operate on them and then find out that you operated on them for the wrong reason.
Right.
Puja, could you just on the Google thing flash the 4 types of paraesophageal hernia and just explain it for the students? Type 1, type 2, type 3, and type 4. If you can just explain the picture for the youngsters.
Yeah, absolutely. So a type 1 hernia is a sliding hernia where your GE junction can go in and out, slide up and down. This is not a large hernia. This is very small. And all sliding hernias, patients don't have to get an operation on. People can live and die with type 1 hernias. Only people who are symptomatic and not controlled on anti-acid therapy are the ones that you should counsel them for surgery. Type 2 hernias are actually emergencies. So type 2 hernias are a patient where this part of the stomach has actually has knuckled up to the diaphragmatic defect, and that will incarcerate and die off and necrose and perforate if you don't operate on them soon enough. So those are the 2 emergencies. I've only seen 1 patient. There are partners of mine who are much more senior to me who tell me they've never seen a patient with type 2 hernia. So type 2s are very uncommon, but if you are being told on a CT scan, or you're being told in a mock oral or oral exam, I should say, then have a low threshold to go to the OR. Don't blow that patient off, and don't sit on that patient because that stomach will perforate. You don't want to take a chance. Type 3 are the ones that I'm talking about. We see that's the most common hernia that you see, where your majority of your stomach has gone up, your GE junction is higher up in the chest, and these are the patients who may have the volvulus, where you can see the stomach has twisted on itself. Those patients are quote unquote emergencies if you truly think that they have volvulus. Otherwise, you can sit on them and decompress them and then operate on them once they're more medically optimized, so you don't rush into them. These patients should all undergo operation in my definition, but that's not a definition that everybody else uses. The reason why I say that, because sooner or later, these patients are going to have some symptoms. If you talk to type 3 hernia patients, they may say, I don't have any symptoms, but if you sit down and elicit from them the symptoms, they will have something or another. Either they've got regurgitation, they've got obstruction, they've got dysphagia, they feel like they can't eat what they used to eat 2 years ago. So they will, they may not be able to eat salads and lettuce and bread anymore when they could before in the past. So they may not be realizing the true gravity of it. Type 4 is when you've got other visceral organs, pancreas, spleen, bowel, and usually those also need to be operated so that you don't get a bowel obstruction. If you ever get a question where a patient comes into the emergency room with bowel in their chest, they are making you go to the operating room. So you detect that patient up appropriately, resuscitate them, get their labs, and then try to go to the operating room, close that defect and reduce everything.
So clinically, in your clinical practice, patients with paraesophageal hernia will present in one of the three categories. One will be asymptomatic, two will be symptomatic, and three will be emergency with complications like bleeding, ulceration, strangulation. So what is your treatment strategy? Three is very clear, you're going to operate. In the asymptomatic versus symptomatic, which one, how do you decide for surgery? Symptomatic, again, I'm assuming you're veering towards surgery.
Yeah. No, symptomatic, you will counsel them that, these, I can get, we'll fix with your surgery, we'll fix your symptoms. You do educate them that there's a 10 to 15% chance that you may have a recurrence within the next 10 years. Not all patients who get a recurrence need to get an operation, because some patients can be managed without an operation if they're not symptomatic. But symptoms are the things that will help you lead the way. If they're asymptomatic and they've got a small sliding hiatal hernia, you won't do anything for them. They may never have any issues.
So an asymptomatic patient you manage conservatively, is that correct?
Pretty much, yes.
So you don't operate on a radiological findings. You look at the clinical findings.
Absolutely not. You are correct about that.
Okay. And the symptoms that are commonly present for patients with hernia are dysphagia, dyspnea, or odynophagia. Is that correct?
Yeah, but not in that order. I would say that most common symptoms are reflux, where they say heartburn, and they're kind of interchange. Coughing is a very common one, hoarseness, and then comes the dyspnea is usually a sequela of recurrent episodes of aspiration pneumonia. And odynophagia and dysphagia usually come on late. They don't have pain on swallowing. They typically will say they've got obstruction on swallowing, and that's because of a large paraesophageal hernia where the stomach is occluding it, much like those Miritzi syndrome that you get on your gallbladder. So this is what's causing the obstruction on your esophagus.
Okay, and the types of hernia you've just shown us 1, 2, 3, and 4. What is the surgery and what is the access? Any of these you do thoracic, or all of them are done via the abdomen?
So most of them are done via the abdomen, only because it's easier to approach. You can do this laparoscopically and minimally invasive. Now, a lot of surgeons who are trained in thoracic surgery can do this from the chest minimally invasively, but most general surgeons are good and feel comfortable with operating within the abdominal domain. And what you do is you try to look at the diaphragmatic defect and you see how big is the defect, because besides bringing all the esophagus and the GE junction way below the diaphragm, then you have to be able to close that diaphragmatic defect. And it's much easier to do it from the abdomen than the chest. You can place a mesh, like I said, if you think that your closure is not good enough, and then you can do your anti-reflux operation. The part when you would go into the chest, which is the Belzi operation, like I said last time, it would be done for somebody who's had a recurrent hernia, and you don't want to wind up back in the esophageal hiatus and operate in the liver bed where there may be more adhesions and scar tissue, or a patient who's an abdominal catastrophe. Say the patient has had multiple abdominal operations in the past, or has meshes that's placed for a ventral hernia repair, and you don't want to go through there. I have a patient who has a very large paraesophageal hernia, as well as a very large ventral hernia. She went to go see the general surgeon for a mesh, and the general surgeon said, well, you're too big, go lose some weight and then come back. But the patient is pretty visible from her paraesophageal hernia, so I plan to operate on her through a Belzi when all this coronavirus is over, so that I can reduce her, because I don't want to wind up through her abdomen and then have her issues with bowel obstruction and delayed, gastric, ileus, and have to sit with her for many days. So I've decided I'll do a Belzi on her.
And these hernias are traditionally more on the left side, is that correct?
Right.
And if they do happen on the right side, why do they happen on the right side?
They usually don't happen on the right side. The only ones that I've seen on the right side are Morgagni hernias. So a Morgagni hernia is a congenital defect where you've got a defect in your diaphragm, and it tends to be on the patient's right side of the diaphragm next to the esophageal hiatus. So you get a defect either in the midline or it extends to the right side. Bactelic hernia, as we all know, is also on the left side, and that's Bactelic, the way I remember it, is back to the left. So Bactelic is on the back on the left, and the Morgagni hernias are anterior diaphragmatic hernias, and they can go to the right side. If you've got a stomach sitting on your right side, there's something wrong, because as you can imagine, the stomach usually tends to go up on the left side, depending on where the short gastrics and the way it lays. Then if that means there must be a component of volvulus, and why is your stomach volvulizing on the other side, unless the patient has a situs inversus.
Okay, all right. Vikas wants to ask you about small kids with GERD.
Ooh, you guys kill me with pediatric questions, but go ahead.
Sorry, he just wants to know, can you tell them a little bit, just for the exam, small kids with GERD, is it common? Does it happen? And what's the treatment?
It does, actually it does. And I'll have to go back to my pediatric surgery days to tell you this, that it does happen. And actually those patients don't do well if you don't operate on them. They almost always need an anti-reflux operation early in their life, because they tend to have more complications the longer they sit. They are not good patients to be on PPIs lifelong, only because they're pediatrics, right? So for the most part, pediatric surgeons in our country take care of it. Those does not fall to thoracic surgeons.
But in a growing child, won't your 2/3 wrap or whatever you do become a stricture when the child comes to you as an adult?
It doesn't become a stricture. It becomes, they get recurrent hernias. So what happens is, if their esophagus lengthens over time as they're growing on its own, then fine. But what you have to counsel them is your wrap may migrate up in the chest. And so they may come back with symptoms of regurgitation and dysphagia. And if you do their workup, you will find out that their wrap is sitting above the diaphragm. So then what you have to do is you go back, you undo their whole wrap, you lengthen their esophagus, whatever it needs to do, and redo their wrap in their normal new anatomic position. But hopefully by that time, they've become a little older.
I'm going to ask you another question, which I asked you last time. It's a repeat question, but just for the students, please help them. When do you decide to do gastric outflow surgeries when you're doing a wrap? Do you do it in every patient or selectively?
No, selected patients. So if a patient has issues with gastric emptying, especially if they're long-standing diabetic, and you see that on an upper GI, the contrast gets hung, I actually have a very low threshold. If I hear somebody, like I said last time, if I hear somebody who has diabetes, I pretty much throw in a gastric emptying study in my workup. So the 5 things that you sit down, as soon as you're getting this question done on your boards, especially oral boards, you should be able to talk through it. You say, I'm going to do I'll consider an upper GI, which you'll pretty much get every single time, an EGD plus or minus, depending on what you're dealing with, because it's an invasive study, a pH Bravo study, unless the EGD shows that the patient has esophageal stricture from reflux esophagitis or has sequela of, LA grade A or grade B esophagitis, where you say, okay, fine, this is the evidence that the patient has, you can skip your pH probe study. A manometry if you're thinking of a surgery, and a gastric emptying study. So those are the 5 things that you should have it memorized like the back of your hand for your board exams. And then talk about whether or not you're going to do a pyloric drainage procedure. That's what we call it. So pyloric drainage procedure with somebody who's got gastric outlet obstruction can be in 3 shapes or forms. You can do a Botox injection intra-op. Most people will say you won't lose any points for it, because you can always do a definitive pyloric drainage procedure later. You can do a pyloromyotomy, which is typically done on babies and not on adults. But I have seen it done on adults. I have a surgeon who's actually my partner who does a pyloromyotomy every single time. Just like a Heller myotomy, you fillet up the pylorus muscle and let the mucosa bulge. Or you can do a pyloroplasty, which is what 90% of the surgeons do. Open it in a Heineke-Micklitz fashion. You open the pylorus muscle longitudinally and you close it transversely.
Okay. Last question.
Not
A
rho and
little.
y, ma'am.
Come
A
on, again.
rho and y is not never required.
A rho and y is you're correct. I said that last time. You can do a rho and y. If you were considering somebody for rho and y, the question becomes: was that patient a bariatric patient, and should they have a better operation for rho and y for a weight loss procedure? Because you're obviously replumbing that patient, right? I mean, if you wanted to leave their native anatomy the way it was, the best would be to do a anti-pyloric drainage. But a rho and y is definitely something that you have as in your armamentarium.
So Vikas stole my next question. The question is, what do you do in GERD after bariatric surgery?
Those are very difficult. So if a patient has had a gastric sleeve, for example, those are extremely difficult because you don't have a gastric fundus left there to do an anti-reflux operation. The only thing you can offer them is that you can pexy their stomach. The way you pexy it, usually with a G tube, and then you will pull it out later because you want to have a fallback plan. Say they can't eat after your procedure, you've at least given them some sort of enteral access. But if they've had a gastric bypass, those patients at least have their gastric fundus intact. But they're extremely difficult because you don't have much stomach to work with. Those are definitely challenging. And I fortunately have not had any cases like that, but I can imagine that they could come my way. And in those patients, your only option would be to do a Rho and Y esophagojejunostomy.
Okay, so probably just bypassed it. Okay, thank you very much. Anybody else has got any other questions?
Something else. I didn't go into this, but I probably should have. Some key components when you describe an anti-reflux procedure on your boards, just like the 5 things that you should memorize for the pre-op testing, you should memorize a few things when you're talking about an anti-reflux operation. So you go into the abdomen, you elevate the left lobe of the liver. If you're doing it open, you divide the triangular ligament and fold the liver so that you can get to the hiatus. You dissect the phrenoesophageal membrane. You identify your vagus nerves, you get into the mediastinum, and the important part that you're looking for is that you're going to remove the peritoneal sac, because if you don't remove the peritoneal sac, they will get a recurrence. You can do that in a piecemeal fashion, just being a logical, while you're in the operating, as a clinician, you almost always have to remove them in pieces. It's very hard to get one large hernia sac in one specimen. And then you try to bring the GE junction at least 2 to 3 centimeters below the diaphragm, perform an anti-reflux operation, make sure you do the posterior dissection behind the esophagus and the stomach. Divide your short gastrics, bring your fundus from the posterior part of the stomach, do the shoe shine maneuver, and then perform your Nissen or Tuppe fundoplication. With your Nissen fundoplication, you make sure that with each bite, at least 2 of your 3 bites that are placed 1 centimeter apart, you grab a bite of the esophagus to make sure that your stomach, your wrap doesn't migrate on your esophagus in the future. And then I typically do a chloropexy. You don't have to say that in your boards, but I take the fundus that I've wrapped around. I take 1 fundus on the left side and 1 fundus on the right side and anchor it to the crus within each stitch, only so that the wrap doesn't migrate up in the chest.
Could you get a picture up of this thing on the Google thing, just so that they understand what you just explained? I mean, excellent way you put it out to them. Just show them a picture so that they stays with them.
So this is a Nissen fundoplication. This patient has had a mesh placed, and you see how the mesh has been tacked everywhere. They pull the fundus of the stomach. You don't see much of a fundus anymore because they've taken that, divided the short gastrics and brought it around and made this a Nissen wrap. And with these 3 bites that are 1 centimeter apart, that they must have taken a bite of this stomach, a bite of the esophagus, a bite of the other stomach. right?
Okay.
And then here's where they've anchored it. Here you see that they've anchored it to the mesh, but I anchored to the crora because I typically don't end up using mesh. I've only used mesh on 2 patients in my whole 7-year career.
Okay.
So you don't use that. And we do an anti-reflux operation at least once, maybe twice a week.
Oh, I see. So
So
what's a shoe shine maneuver?
So shoe shine maneuver is a, the reason why we talk about a shoe shine maneuver, and I wonder if I can find a picture, it probably is better seen in a video, is basically, yeah, that's not bad. Is basically when you take that,
No, it's in an abstract form. Just go back to the, no, it's not there.
I don't know why it doesn't let me go back.
Just go back on your,
yeah.
yeah.
So the reason why it doesn't, when you do the gastric and you divide the short gastrics and you bring the fundus of the stomach, the reason why you do this shoe shine maneuver is you don't want extra stomach to be left behind the esophagus. And then when you do this wrap and you close it, that this becomes too loose. That wrap can be pretty loose. The other thing I should mention, and this nobody will ask you on boards, but when you start operating on these patients, don't leave a huge part of gastroesophageal fat pad here. That fat pad, most likely during your dissection, you've already devascularized it, and it'll just become a fat necrosis. And once it sloughs off and dissolves, your wrap will become too loose. That patient will start complaining to you again that I'm starting to have reflux symptoms, because that just adds a buttress during the operation. So try to take away that fat pad. Obviously, don't damage the vagus nerve, and then do your wrap with the shoe shine maneuver.
So it's moving front and back, isn't it, at the back of the esophagus?
It's moving your gastric fundus to and fro from your left hand to your right hand to make sure that it's nice and snug around your esophagus.
Okay, fantastic. I really enjoyed that. Thank you. Thank you very much, Puja. Anybody else has got
Yes,
any
sir.
other
Can I
questions
ask one
to
quick
ask?
question? Yes, sir.
Yes.
Yeah, who is that?
Vikas.
Yeah, go ahead.
So if we have a patient with Barrett's, if there is high grade dysplasia, we'll do a EMR that time, and then we'll follow every 3 months, right?
No.
Yeah.
Yeah, so EMR patients typically don't have nodules. High grade dysplasia patients don't have nodules per se. If you see a nodule, then you should do an EMR. But if you only see bears, you biopsy them, you abort the case, you wait for your final pathology to make sure that this is high grade dysplasia. Then you bring them back for the radiofrequency ablation. You only EMR nodules, and then you monitor them.
So what is the treatment for Barrett's with no dysplasia, low grade dysplasia, and high grade dysplasia? These 3 categories we'll find. So how we go about them? Yeah,
that's fair. So you low grade dysplasia and metaplasia only. If you don't have any dysplastic cells, but you've got the first early signs of undergoing changes, you can watch and you can give them anti-reflux therapy and counsel them. Why don't you undergo and see a thoracic surgeon or a general surgeon and get an anti-reflux operation? Because in case this progresses on, you're protected. So you don't do any intervention for low-grade dysplasia. But once you hit high-grade dysplasia, you must do something. And that's when you do radiofrequency ablation. This has changed over the past 10 years. So if you're about to do your boards and you think that you're going to go off by the information 10 years ago and you're going to recertify, go refresh your what's the latest guidelines, because these are the most latest guidelines. Is not to operate on low-grade dysplasia, but high-grade dysplasia, do a radiofrequency ablation and then monitor them. If they do have, the other thing I was going to say is if the patient has high-grade dysplasia and say they come to see me, you want to space their radiofrequency ablation and your surgery by at least a couple of months. So if they had, if they're going to undergo your surgery, tell them that you should not undergo a radiofrequency ablation for 2 or 3 months.
So the pathway is radiofrequency ablation followed by anti-reflex procedure.
Or vice versa, but you should not do them both in the same setting.
And even for low grade and no dysplasia, we'll advocate them to go anti-reflex procedure or only medical therapy.
No, I would say that you should always counsel them about an anti-reflux operation, and they can decide whether they want to undergo it or not, and let the patient decide. But they should know the pros and the cons of your PPIs And especially if they continue to progress while on PPI, say you got a low-grade dysplasia patient, or you say you got a metaplasia patient, you put them on PPIs, they come back for their surveillance endoscopy in 3 months to see if it's gone or not, and it hasn't, and now it's low-grade dysplasia. Those patients are the best patients that actually should go see a surgeon, because you don't want to be sitting on them to progress to high-grade dysplasia. So you want to catch them earlier.
What's the role of esophagectomy in these cases?
So anything that's what we called, for high-grade dysplasia, anything that's greater than 3 centimeters. So long segment, I was thinking of the word. It's called long segment Barrett's. The patients who have long segment Barrett's should undergo an evaluation for surgery. And believe it or not, long segment Barrett's qualifies anything above 3 centimeters. But let me tell you, there are so many GI docs out there that will not send me a patient or send another surgeon a patient who have Barrett's that is 4 or 5 centimeters. So just because that's a definition, they don't follow it, because obviously more patients are very afraid of an esophagectomy, and so are the GI docs, so they never even discuss it with them. We recently, and we had a huge deal, we made a huge deal at our institution about it. We had a patient who had a 10 centimeters Barrett's that was managed with serial radiofrequency ablations for the past 1.5 years. And when everything was failing, he was referred to our chief of surgery department, the department chief. By that time, he was already stage 4. He had stage 4 esophageal cancer, because what the RFA does is the radiofrequency ablates the inner lining of the mucosa. So every time you scope them, you don't see anything that's happening underneath that mucosa that's already healed, unless it's a nodularity. So this whole time, this patient was missed out that now he has esophageal cancer that's gone stage 4 and had supraclavicular nodes that were positive.
Do we know if Barrett's is hereditary, and is there a role for family screening?
Unfortunately, right now, we don't know that. There is a gene, the TP53, that people have linked to Barrett's and for esophageal cancer, but nobody has found a biological marker or a genetic mutation per se. There's some discussion that it could be familial, but what's the familial defect, we don't know.
No, but endoscopic screening is what I was asking. Should the family members also have an endoscopy?
You know, whenever we have a patient who's had a family member who's had esophageal cancer, we say you should, but there's really no guidelines. The SAGES and the American College of GI both don't give us guidelines on patients with family history warranting an endoscopy.
I see. But traditionally, you would suggest them.
We only suggested when the thoracic surgeon sees the patient. They don't get.
Sure.
They don't get the primary care doctors, the family practitioners don't recommend it.
No, but can they say that in the board is my question.
It's a good question. I don't think, I mean, I would say that there's no reason to support in the literature, but since the patient is presenting with esophageal symptoms, I would say that he would benefit from an endoscopy prior to me putting them through a fundoplication, especially because there was a family history of esophageal cancer. If they're giving it to you on boards, they're probably asking you to think about that.
Yeah. Okay. Fine. Thank you very much, Puja. That was really, really enjoyable. I have to say, fantastic. We love to pick your brains about this. Your knowledge of the esophagus is immense, and your clarity of thought it really comes across very, very starkingly. So thank you very much for your help. On behalf of all these young students, I'd like to thank you for taking time out from your busy schedule and teaching us about the esophagus. Thanks once again.
I enjoyed this too, so this is good for me as well.
Excellent. Thank you. Okay.
Right.
Good night to everybody. I hope you enjoyed this session, and we will be putting up this video on the YouTube channel soon. Thanks. Good night, Puja.
Take care.
Thank you, sir. Thank you, ma'am.
Thanks.